Why present? Because some of the newer medications which we are using for diabetes, there's a lot of new information coming up, making a paradigm, actually a paradigm change in the way we look at diabetes and how we treat it. So this is how the plan of the talk would be, just a reflection on the present guidelines, because this is for the general HCPs an important way to look at how do I treat a patient with diabetes. I'll just spend a few seconds on that. The main focus is going to be on SGLT2 inhibitors. I'm sure during the next day and a half, you would hear much more about it. So I would be very brief and crisp about the newer information we've got about SGLT2 inhibitors, the CVOTs, the future extra glycemic benefits, which is the most exciting latest thing about this group of drugs, and then go on to future drugs, devices in diabetes. So the present guidelines, we all know, and all the young people who come for training with us, our DNBs, our residents, everybody, I tell them that this one slide can form the basis of correct and ethical treatment for type 2 diabetes, where these are most important things. A1C, how much do we keep it? The guidelines say that, okay, A1C should be 7, A1C should be 6.5. But if you read all of these and keep it in mind, there is no complexity in this slide, but this is the basis of how I treat my patients. If a patient is young, the A1C has to be here. The patient is a very productive life. Patient does not have any complications, has an excellent quality of life, and he's progressing. I would give him a stringent A1C without the risk of hypoglycemia. That is very important. So this slide set is all for you, and I would keep it back here. You could go through these things, and shorter duration, greater life expectancy, all these things are important determinants where we decide what should be the target for A1C. And this is a feeling I have, though there is no data to that. I feel that our Indian patients, if without hypoglycemia, you can achieve an A1C less than what the international guidelines say, I would definitely go for that. But essentially, hypoglycemia should not happen. That's a big deterrent in patients' acceptance towards progressive changes in medications for diabetes. So this is the latest ESD ADA 2018 guidelines. Now what is interesting, and I'm very happy that they've done in these guidelines, is that they have divided the population into various segments. One, patients who have established heart disease or have CKD. Now CKD, to our older understanding, was a creatinine which is more than 2. This is just a random number I am quoting. But now CKD includes those, and the definition clearly says it starts from albumin excretion in micro amounts to macro amounts to derangement of their creatinine. So it's a continuum. So these two patients, and the data is very clear, few of it I will share with you, and the scientific session would include all of these categories of patients to decide which is the right drug in these patients. It's extremely important. So probably these few first slides are extremely important for us as a guide to what to use to ensure our diabetics live a long life without complications of diabetes, and that's the essence for treating diabetes. So whenever you have established heart disease, we have GLP-1 and we have SGLT2 inhibitors with clearly proven benefits as far as their cardioprotective nature. Most of the drugs are either cardio-neutral, and certain group of drugs which the center I come from, which has a large bulk of cardiac patients like TZDs, our use is extremely less. So I may not be the right person to comment on that. But what is also very important, and then, so one is this category, and then we come on to the other category where we have patients in whom, like an elderly, I'll give you an example, in whom you want a glycemic control, yes, but at the same time you don't want hypoglycemia. So they put the drugs here, which when added on to metformin is a less chance of causing hypoglycemia. So our focus changes from that just the A1C to going to hypoglycemia should not happen. And then we know that in our clinics, most of our diabetic patients are overweight or obese. So we need a drug after metformin which can not just give good glycemic control, but also help in weight loss. So we have two drugs, the GLP-1 and SGLT2 sitting right there. But the important thing to understand is these new drugs are expensive. Not all patients can afford it. So affordability, before I write my prescription, I assess and at times would ask my patients about that this is the X cost of therapy and I expect you to take it for a long period of time. Would you be able to do that? It's only after this would I go on to these expensive medicines, though very beneficial as far as weight loss, kidney protection, heart failure reduction, all these things going on and on. And very pertinently,